Dr. David Hamer, who is the Associate Professor of International Health and Medicine at Boston University School of Public Health, as well as the School of Medicine. He is specialized in infectious diseases and has particular interest in tropical infectious diseases such as malaria. Thank you, Doctor.
Good afternoon. It's a pleasure to be here. Appreciate being invited. I'm going to talk sort of generally about HIV infection, and I was told that somebody else may be speaking a little bit about the epidemic, so I'm going to go through the first couple slides very quickly, and then focus a little more on the virus, a little bit on treatment, and then I'm going to talk about some of the different kinds of services we have available at Boston Medical Center. And just very quickly, this just shows the estimated number of people living with HIV and adult HIV prevalence, both globally between 1990 and 2007, and you can see a dramatic increase over time, but also in sub-Saharan Africa, which accounts for a substantial burden of the disease. And these are pandemic totals from 2007, an estimated 33 million people living with HIV, about almost 3 million new infections in 2007, and about 2 million deaths. But we are making progress in treatment, and there are an estimated 3 million people now that are receiving antiretroviral therapy, and worldwide, but especially there's been a massive scale up during recent years through the PEPFAR program, the Global Fund, and other programs. So the virus is a relatively complicated virus. This just shows sort of the scheme of the virus, and this is not a molecular biology lesson, so I'm just going to go through this quickly, but there are a number of different proteins. The surface protein GP120 and transmembrane protein GT41 are important for at least some component of immune response, but they're also proteins that undergo sort of constant mutation and change. And those and some of the other additional molecules, because they're constantly evolving, make this a very difficult virus to both treat, because it can evolve quickly and develop resistance, but also for vaccine development. And really, I think all the attempts to develop a vaccine thus far have been frustrated, including some of the more recent attempts. And it's a member of the lentivirus family. There are really two types of virus. It's an RNA virus, and there are a couple of key enzymes: the reverse transcriptase, protease, and integrase enzymes, and I will show a little bit more of those. Each one of those is a target for some of the major drug classes that we have available. And this shows the life cycle. It's a simple schematic of life cycle and then specific drug targets. It starts out with binding of the virus to CD4 molecules and then CCR5, which are molecules on the surface of lymphocytes. They're taken in, and actually this is an older schematic, but there are now drugs that block CCR5. That there's a new class of drugs that became available just in the last 2 years, at least in the United States. These are not yet available in West Africa or many other parts of the world. And then there is uncoding the virus. It's transcribed back to DNA, so reverse transcription. And a lot of the drugs we have available bind to that enzyme and interfere with that process. So there are really two major classes. There are nucleoside reverse transcriptase inhibitors, and then non-nucleoside. They have slightly different sort of chemical structures. And you can see many of the names that are listed here are drugs that, for those of you who know a little bit about HIV, are likely to have heard of. And then the virus often integrates itself into the host genome, and it can hide out there for many months or years, which presents one of the challenges to management of the infection. And then eventually it starts to reproduce. Messenger RNA is produced. It makes a long chain, basically a long protein, and a protease chops it into these different structural and other molecules that form the virus. So this is another site of action, the inhibition of the protease inhibitors. And actually earlier on, this phase of integration that you see here, when it integrates into the chromosome of the host, there's an enzyme called integrase, and there is now one integrase inhibitor that's available in life cycle where medications are active. This is just a very general scheme of the clinical progression of HIV. It's a little bit of a complicated figure. This shows CD4 lymphocyte counts, and so one of the more important markers for monitoring the sort of state of well-being or sickness of an individual with HIV is the CD4 count. And during the initial infection, the CD4 count is normally around 500 to 1100 or thereabouts. During the initial infection, there's an acute drop in CD4 count, and then there's a big surge in the amount of virus. And so you see the y-axis on this side is culturable plasma viremia. So it's basically the amount of virus in the blood. And there's a big rise in viremia, and this is during acute infection. So during this phase of infection, if you have sexual contact or some sort of contact with a person who's infected, especially with their blood, then you have a very high risk of that person transferring the infection to another person. Eventually, the immune system kicks in and is able to at least somewhat contain the virus, although not completely in most cases. And there's a jump back up the CD4 count. The viral load goes down to a very low level in some people. And every individual is different. There are a lot of factors that play into this. But with time, what happens is the CD4 count stabilizes in different set point for each person. It can be as low as 200 or 300. It can be as high as 700 or 800. But then over many years or many months, depending on the individual, it gradually declines. And our current guidelines for starting treatment suggest considering starting treatment with a CD4 count of around 350. And that's changed over time. 10 years ago, we were treating everybody if they're infected. There was sort of an adage at the time, hit hard and hit early. But what happened was, over time, we started seeing a lot of chronic side effects from medications and increased complications, especially metabolic side effects. So there was a trend towards starting later, but it turns out if you start too late, then patients can't sort of heal their immune system. They can't reconstitute their immune system. And so we're now sort of trying to find what is the optimal time to begin treatment. That depends a little bit on both the CD4 count and viral load. But when the CD4 count gets to be very low levels, less than 200, that's technically now a diagnosis of AIDS. If you get less than 100, your risk of opportunistic infection goes up drastically. Patients with really advanced AIDS, I've seen patients come in with no CD4 cells, or just fewer than 10, and they're like a human petri plate, and they can become infected with viruses and parasites and fungi and bacteria, and sometimes many of these things all at the same time, and it's just a horrible thing to see. So we try, ideally, we don't want to see people coming in at this point, but even in Boston today, we have patients come in with very low CD4 counts that have been in denial or have not sought treatment, have not been diagnosed, and are very, very sick. And this is a little bit like Dr. Punjabi's case. This is actually from Partners in Health from Sarita Koenig and Paul Farmer, but just a picture of a man who came in with very advanced AIDS, with severe wasting. You can see he's lost an incredible amount of weight. Actually, this person had both advanced AIDS and tuberculosis. And he was placed on anti-tuberculosis therapy and eventually on antiretroviral therapy, and this is the same man many months later. So treatment can really make an incredible amount of difference in individual and even within a population. Many countries in sub-Saharan Africa have seen a gradual drop off in average life expectancy. I'm actually amazed. Liberia, relative to Southern Africa, doesn't have as many HIV cases, but the life expectancy is similar to countries in Southern Africa, where it used to be longer, but they've lost a lot of years because of the AIDS epidemic. And this just the next couple slides, a little bit on treatment, and this just shows access to antiretroviral treatment by region as of December 2007. And we've made progress in sub-Saharan Africa, Latin America, and the Caribbean, less so in Southeast Asia and the Indian subcontinent, but still there's a long ways to go. And I actually personally, some of the work I do involves adherence and trying to make sure that people, when they go on treatment, they continue to take their medications. So that's one of the major goals of treatment. Obviously, helping people to access treatment, is very important. And then scaling it up so that it's available to different populations, especially those who have the hardest time accessing health care. Trying to make sure it's sustainable over time, and then ideally that